All right, very good. So we are going to start off by just looking at the exam structure. So the structure of the PTCB exam. So all of the questions, there's 90 questions on the exam, it says, but there's really only 80 that count. They throw in 10 questions that they're testing out to see if they're going to use it in future exams. But you won't know which 10 questions are the ones that don't count. So, of course, they do the same thing with your pharmacy boards. They do the same deal. Um, that being said, the question breakdown is generally as follows. So out of those 80 questions or 90 questions, 40% of those are going to be based on medications. And that's also going to include your calculations. So that's going to include calculations based around medications, days supply, um, all the way up to the dilutions and allegation problems that we're doing. Now, there might only be one or two of those questions. There's only 80 questions in the actual exam itself. Um, one or two questions that might be like, like genuinely difficult calculation problems. But some of them might just be like, read this prescription and tell me what the day's supply, like how many days until the patient runs out of their medication. And then that's a gimme, right? Um, and then medications, of course, that also counts as what we've been doing. So like generic to brand, brand to generic, the different drug classes, the different side effects or adverse effects which might be associated with those drugs. And also some stuff on like drug interactions. So if a patient is, they might give you a list of drugs that the patient is taking, and they might say like, which of these drugs interacts with the other ones? And so, for instance, it could be an actual like contraindication reaction. So it might be something along the lines of, oh, they are taking two blood thinners. They absolutely should not be on both of those blood thinners. So you would pick the blood thinners in that case, right? If they're on Coumadin and like Xarelto or something. It might just be, say they're on an antidepressant, an SSRI, and they're also taking an antihistamine, like an allergy medication, along with a benzodiazepine. What does that mean? They might get dizzy, they might fall down, especially if they're a fall risk, like you would see in a hospital, right? So it's medication's a very, very broad category, and rightfully so. It's about 40%, almost half of the exam. Patient safety and quality assurance, that falls under what I was just talking about, along with how I was saying those do not use abbreviations, the pharmacy like processes, the tall man letters we talked about in lab to prevent errors, the how techs and pharmacists check on each other to make sure that things are transcribed correctly. And then patient safety, of course, that also involves drug interactions, narrow therapeutic index drugs. We've talked about those NTI drugs like digoxin, those antiarrhythmic drugs or other drugs that are very, very potent, right? So they have a narrow therapeutic index, meaning that it's very easy to overdose or underdose the patient. There's a very small sweet spot for a narrow therapeutic index drug in order to reach a therapeutic effect. So that also falls under the realm of patient safety. Order entry and processing, that's exactly what you have been doing in lab with Melissa. So that just goes through the process of how it actually is to work in a pharmacy. It's probably going to be more retail focused. So it's going to be focused more on, like, say, uh, the typical pharmacy operations of like a CVS or a Walgreens versus the typical operations within a hospital. That's not to say there won't be hospital questions, but there might be a lot of things where it's like the patient comes up to the counter and hands you a prescription, like a lot of problems along those lines. And then it might be like, well, what do you do? And then the first answer to that might be, oh, I'm going to check for the patient's date of birth. I'm going to see if they have a profile. If they don't have a profile, what do? We create one. What do we ask them? We ask them for their allergies, for their doctor, that kind of thing. So that's typical pharmacy operations. Also goes under inventory and some of those other like math problems that were more like pharmacy operation problems. And then lastly, 12.5% is the law. So it's federal requirements. So again, not state of Massachusetts specific, but federally. So a good example of that as well is for like a controlled substance inventory, for instance, you will never be in a pharmacy that only checks the controlled substance inventory every 2 years. But that is the federal law. So if there's a question asking how often do you have to check the inventory, it's every 2 years, as opposed to usually it's weekly or every 2 weeks in most pharmacies. So as we scroll down, as it says, focus your study to be proportionate to those percentages. You should aim to cover as wide a base as possible, preferably all topics. Of course, that's a lot easier said than done. But by leaving out more subjects, you risk over-focusing on subjects which in the end may not get asked in a way that you had hoped, thereby leading to failure in the topics you left out. So that's why it's a fairly challenging exam. Like you do have to paint with a broad brush, right? Because there's only 90 questions. So they're not going to ask you about every single drug you study, obviously, but you have to be ready to be asked about every single drug that you studied. The passing, so I believe, I don't know if it says on here. I think, yeah, it's, but I know that the passing score, it's also graded on like, it's complicated the way they calculate it because I think it's graded on a curve based on everyone else's who's taking the test across the country based on their scores. So like that 1400 for some people might be different for others, depending on what the average curve that the test is how it's calculated. So it's kind of like a moving target, depending on like they adjust it for every time they rewrite the test because the questions are different. So I think that's part of how they try to make it fair. Also, Brian just showed up. Hi, Brian. Mhm. Sure. I don't know the specific hospital policy. However, you can take it up to 3 times. But I don't know. You'd have to ask your Bay State or Holyoke for you guys. Yeah. Yeah.
Is there, it might be a silly question, but there's no notes, no calculators.
A good question. Yeah, so you're allowed to have calculators. So if it is like how I took my pharmacy boards, then I can tell you exactly what to expect. So usually they will have a calculator that's built into the actual exam. So it's like the calculator is like on the computer screen and you can calculate. Sometimes they also have like the hand calculators as well. But usually I think it's on the computer screen. And then for notes, they do give you like scratch paper, or they give you like a laminated paper and you take notes with a like a expo marker. So you will have
Yeah,
that.
but
You can do the
no bringing
calculations out and
our
stuff.
notes in. We can't bring our notes in, correct?
No. Yeah, no, you can't bring any notes. The testing center, it's like going through TSA almost. Like they take your glasses off and they spin it around to make sure you don't have like Google Glass on. And yeah. So it's very like hardcore. Like you empty your pockets, they make sure you're not bringing anything in there with you. Like you put it into a locker while you're in the exam room. So it's very secure, but that's what you expect.
Okay, thank you.
You got it. Great question. Um, let's see. Oh, yeah, study smarter, not harder. Take home message, study all these things proportionately. I mean, this is all pretty much common sense at this point. Knowledge and accuracy is accurate. No kidding. You're taking a test. Let's see. So improve, and I know they're saying here like the 2020 PTCB exam, but it hasn't fundamentally changed since 2020. 2020 was the year they did it, like kind of revamped it, which is actually going to be in your guys' favor because they revamped it to be a little bit more hospital focused than it was before. Even though I think it is primarily taken by like retail pharmacy technicians, they do have probably a few more questions about like hospital policies and procedures, which is good because you guys are familiar with things like OSHA and HIPAA, because you've already been trained in that field. All right. So that being said, we'll get started with our review slides for the night. So 1 second, let me just transfer over. Is it? All right, and I will pull up the chat so I can see you guys reply. But we are going to start off much the same way as we started off before. So we are going to do some matching. So let's do some matching. Brand to generic. So we got the brand name drugs on the left, the generic drugs on the right. And I'd like to see, you can type in the chat or everyone take a moment. You can maybe write them down, do some exercises, and we are gonna match these drugs up. G to 4, very nice. I already got G to 4. So what is G? Yep, Humalog, insulin Lispro. So perfect, already got that. So insulin Lispro, the way I remember it, so Humalog, it's your rapid acting insulin, so it's the one that you would take before meals. So remember, we had our long-acting insulin, like the pens and stuff like that you inject, and that's once a day. Humalog, it usually comes in vials, and that's the ones where they inject right before the meal for that little extra boost that people with diabetes need when they're ingesting mealtime sugars and carbohydrates, and they need help with that. So I remember it's the rapid acting insulin because insulin Lispro is rapid Lispro, right? It's little things like that get you through pharmacy school or pharm tech school. So yeah, Humalog is insulin Lispro, and it is the rapid acting insulin. All right, what else do we have? E is 1. Oh, B is 1. Yes, easy, right? Ibuprofen, Advil. What type of drug is that? It's an NSAID, yeah, which means beautiful. Yes, non-steroidal anti-inflammatory. Yeah, so it's a non-steroidal anti-inflammatory drug used for mild to moderate pain. Do you guys recall any counseling points for an NSAID? For any NSAID, it could be for ibuprofen, but it could be for any other NSAID. Yeah, take with food, right? Because it can be rough on the stomach. Yeah, certainly. Maybe avoided people with like stomach ulcers or other like digestive problems. Like you wouldn't necessarily want to give it to someone who has heartburn all the time because they're already having indigestion of some sort. So yeah, very nice. Okay, what else do we have? C is 8. Oh yeah, speaking of GERD, we got, whoa. Speaking of GERD, we've got Protonix, pantoprazole. How did you know that? Unless have you just like completely memorized it, or do you have a trick for knowing? Oh well, that's easy. Yeah, very good. Yeah. So C Protonix is pantoprazole, and what kind of drug is that? What would be the drug class? You're talking about it last review session. It is, yeah. But like, how does it work in the body? I guess I'm asking its mechanism of action. What is proton pump inhibitor? Yes, yes. And so Protonix, right? It tells you what it is right in the brand name. So Protonix, it inhibits those proton pumps, which are within the stomach, which cause the stomach to be acidic, so you gain that stomach acid. And Protonix, otherwise known as pantoprazole, you can tell the prazoles because those are all the PPIs. They all end in Prazole. All right. Next up, what do we have? D is 5, Deltasone. Yeah, Deltasone is the brand name for prednisone. Now, you hardly ever see Deltasone as like a brand name. But yeah, Now, prednisone. What makes prednisone different from ibuprofen? The steroid. As so it's an anti-inflammatory, but it's a steroidal or corticosteroid anti-inflammatory, as opposed to a non-steroidal anti-inflammatory. And then what are maybe some counseling points we would tell a person who's taking prednisone? It can, yeah, absolutely. Absolutely. Yeah, it can mood changes. Yeah. No, really, it does. It does. Absolutely. It also, with long-term use, if you're using prednisone for a long time, can also cause weight gain because it increases hunger. So some people will inadvertently gain weight if they take it for a long period of time. Maybe if they have like rheumatoid arthritis and they're taking it chronically, that could be an example of when you might gain weight from taking prednisone. But very often it's used to deal with inflammation during like what conditions? Yeah. Hmm. So respiratory stuff, right? Any sort of respiratory issues, like whether it's an infection like COVID or something like that, you give prednisone. Actually, you give uh what is it that you give with COVID? Dexamethasone is another um corticosteroid. It's a little bit more powerful than prednisone, and they give that for the COVID patients. Also, dexamethasone, they give it for it's so powerful and it's so good that it's actually quite useful for patients with meningitis. So especially little kids, and they found that if you give dexamethasone to kids who have meningitis, it actually helps preserve their hearing because meningitis can sometimes make a little kid like lose some hearing or go deaf. And they found out in studies that when they treat the meningitis and they with whatever antibiotic is necessary or antifungal for that matter, they can also have a very, very good effect on hearing outcomes with those patients. So it even helps inflammation within the ears, in addition to the lungs and the brain and anywhere else. So yeah, prednisone, definitely a drug of choice, especially in hospitals. All right, let's see, what else do we have? Is E estrogen? That? Oh, wait, I'm looking at the wrong one. Yes, it is estrogen. I was looking at the next slide. Yes, E or Premarin is estrogen. Now, I have a disgusting way that you can remember this if you guys are ready for it. Do you know how they make? Yeah, no, yeah, you guys are. Yeah. But do you know how they make Premarin or how they get the estrogen for Premarin? Yeah. Well, it's you're close actually. So it is a farm animal. So Premarin kind of sounds like mare, right? So like a horse, like a female horse. So they collect the horse going number one, and then they separate the estrogen from it, and that's how they take it to be synthesized. So that is that's how you get Premarin, that estrogen supplement. But I mean, hey, people complain that drugs are like all synthetic and not all natural. Well, there you go. There's your natural source, right? So, but Premarin, and now you won't forget that, right? Remember, Premarin comes from the female horse. It's the estrogen. So, and what could that be used for? Why would we give someone estrogen? Yeah, yeah. If they're having hot flashes, menopausal symptoms, absolutely. Also, if they're transitioning as well, absolutely. Or if we have, or maybe they just have a deficiency in estrogen and they're not even going through menopause. It could be used in IVF, in vitro fertilization as well. They might take estrogen supplements depending on, or estrogen prescriptions depending on when they're trying to have the baby, that kind of thing. But yeah, so that is estrogen. What else have we got? We are rolling along. Ultram, tramadol. Okay, great. Now, what type of drug is tramadol? Mm-hmm. Yeah. And ooh, if you get it as a shot, that's yeah, usually it's in IVs, I would say. Ooh, yeah, I don't know about that specifically. I mean, I know it's a very common oral drug as well, or IV, especially in hospitals because what type of pain medication is it? Like, is it an NSAID? You're on the right track, Evelyn. It is a C4. Very nice. So it is a controlled substance. It is a Schedule 4, which, and what pain medications are generally scheduled? What type of them are generally scheduled? Opioids, right? So it's a weak opioid. It's not like a OxyContin or oxycodone, but it's a weak opioid, which carries with it, as you learned in like the Narcan training as well, that potential for dependence. Um, Absolutely. So then, but yeah, tramadol, it's a nice option though, as sort of a step up from if they're having a lot of pain and they're not responding to an NSAID, tramadol might be the next thing that they recommend. So like when would you use it?
No,
oh, oh, Ultram. Yeah. So A goes with tramadol. And it's easy to remember, right? Tramadol. Yep. Yep. Tram. All right. Let's see. Any others? Oh yeah, we got two more. F is 6. Very nice. Very nice. So what is Zalatan or latanoprost? Something you don't always think about. But if you have really bad seasonal allergies, you might think about it. Not quite. Someone Google latanoprost and tell me what kind of dosage form it is. Yeah, it's for glaucoma. So how do you think it's administered? Eye drops. Yeah. Latanoprost are your eye drops, right? So yeah, they help reduce the ocular pressure in glaucoma patients. So if you have glaucoma, there's a high buildup of pressure within the eye, which causes visual impairments, and it can also cause damage later on if it goes untreated. So what latanoprost does is it releases that intraocular pressure, takes some of that inflammation out of the eye, and it's quite effective at doing so. So you see these as eye drops all the time. Latanoprost is probably like the one of the most common eye drops I think you would see. All right. Uh, and lastly, Xanaflex. What's our last one? Process of elimination. Tizanidine, either way. Um, so what do we know about tizanidine? Is it what? Um, Broadly, I think yes, actually. Um, but what's it treating? Let me double check that before I tell you.
Hey,
Yeah.
Dominic,
Oh yes, what's up, Sharon?
could you just repeat some of what the audience says because we can't hear it at all?
Oh, okay. So we're talking about tizanidine for Xanaflex. So it's H goes to 7, which is tizanidine. And I'm asking what they would use tizanidine for, and they're saying muscle spasms, which is correct.
Thank you.
So 1 second, let me just check to see if one member of the audience asked if it was an antagonist, and I don't want to give the wrong answer. Yeah, alpha-2 antagonist. So very nice. Very nice. Yeah. And so for the short-term treatment of muscle spasms or muscle spasticity. Okay. So tizanidine, very good for muscle spasms. But mainly in the short term, though. It's not like supposed to be prescribed as a long-term type drug. What might be some side effects that would go with muscle spasms? Or that would go with tizanidine, treating muscle spasms with tizanidine or Xanaflex. Drowsiness, absolutely. Yeah. Anything else? Huh? Nausea, very possible. Yeah. Dizziness. So it's one of those classic medications where you have to say like, do not operate a motor vehicle or heavy machinery until you know how this medication affects you specifically. And it, of course, would compound those same dizziness and drowsiness side effects would get worse or compound if you're taking it along with other drugs which also have dizziness or drowsiness associated with them. Okay, very nice. So we move on. Let's do generic to brand. So I'll give you guys a little bit of time and start thinking about them. Feel free to type in the chat too. All right, who has some answers for me? E is 2. Yes, it is. Lantus. It's our other insulin, right? It's our long-acting insulin that I was talking about in the in just the past slide. Yeah, so E is 2, Lantus is insulin glargine. So that's our long-acting insulin as opposed to our rapid-acting insulin that we talked about on the previous slide, which was Humalog, right? All right. F is 4. Yep, typical, right? Guaifenesin or Robitussin. So what's that for? Coughing, right? And it's easy if you know Spanish because it's tos, right? So yeah, so Robitussin. Yeah, and guaifenesin, it's also in, you might see the brand name as well, Mucinex. Mucinex tablets are also guaifenesin. And I will let you in. They do not help at all. Yeah, water is just as good. Like a full glass of like 8 ounces of water is just as effective as taking Mucinex. So it is a scam. Do not buy Mucinex. Robitussin could be helpful if it's maybe with codeine, like Robitussin AC, to prevent coughing, because codeine is the real cough suppressant part of it. But like guaifenesin by itself, it really doesn't do much. If you are all stuffed up and you take guaifenesin to try to, get rid of the mucus, just hydrate really well, or take like Sudafed or something, and that's going to be much more effective at drying you out and getting relief for those symptoms. All right, next up. C is 1. Yeah, lamotrigine, Lamictal, lamb and lamb. Yeah, sometimes they're easy like that, right? So what does lamotrigine do? Yeah, absolutely. Yeah, so it's could be for bipolar disorder. And seizures as well. A lot of times I think lamotrigine is one of maybe the go-to drugs for seizures, especially when you compare it to some of the other ones like Dilantin or phenytoin. Lamotrigine, they quite like it for seizures just because it seems to be a little bit more effective. And then you can also treat, if they do have an underlying mood disorder, you can have them treated for both things at the same time. So yeah, lamotrigine, Lamictal. What is really important, what's super important with to counsel a patient on with anti-seizure drugs? What would you absolutely want to make sure the patient knows before they start or stop taking an anti-seizure drug?
They need to consult with because it could give them an adverse side effect and it could harm them.
Yeah, absolutely. So yeah, they would want to consult with the physician because it could give them an adverse side effect or harm them. Absolutely. Especially with anti-seizure drugs. If you suddenly stop taking the seizure drug, what happens? Your brain rebounds. And because your brain has been compensating while you were taking the seizure drug. So if you suddenly stop taking it, your brain's like, whoa, I'm not being, inhibited anymore. So usually people, especially if they stop like cold turkey, they will have seizures. So for any seizure drug, if they're trying to get a patient off of it, they're going to titrate that drug. Titrate by either as they go on it, they're going to titrate it up until it's effective. As they go off of it, they're going to titrate it down. And if they're titrating it down to switch to another seizure drug, there is a possibility that that patient might be taking 2 seizure drugs at the same time, because we do not want them going without that therapeutic effect. We do not want them having seizures, especially if they're transitioning from one seizure drug to another. So there are whole protocols written up in hospitals and in, I'm sure the American Society for Epilepsy has these whole protocols where they specifically detail how you dose down Lamictal in favor and while you're dosing up another seizure drug to prevent drug interactions from happening. All right. What's next? Is D6. Let me see. Yeah, very nice. Yes. So D is 6. Losartan is otherwise known as Cozar. So what type of drug is losartan? For high blood pressure, very good. It's an antihypertensive. And we have our 2 main antihypertensive drugs, right? We have our ACEs and our ARBs. So is it an ACE or an ARB? And both end in very specific endings. It's an ARB. An ARB for sartan, right? So yeah, losartan or Cozar is an ARB, an angiotensin receptor blocker. And that is a class of medications along with our ACE inhibitors, all of which are used for high blood pressure. And the nice thing about losartan and ARBs in general, really a very nice side effect profile, as opposed to ACEs. Do you guys remember the ACE inhibitors? What the weird side effect that goes along with ACE inhibitors are pill drugs? Oh, that's one. That's one. Although that's more so with statins, but it's possible. But with the pill drugs, we have a dry cough, right? Remember that? Yeah. So it's because it's weird because it's not like associated with your heart or anything. It's just a byproduct of the drug being metabolized in the body. But ARBs don't have that dry cough. So if a patient's complaining of a dry cough after they've been prescribed an ACE inhibitor, that's when you switch them to Cozar. You switch them to losartan or another ARB medication. How's it going, Kermit? Oh yeah, wait, Kermit, do you want to do it over here as well? So we have a guest.
Thank you all on your last official class, and these other things you're continuing to do. I've had another commitment on Thursday nights most of the time, and was actually on vacation the last 2 weeks, but I'm glad I was able to see you again. I've been hearing great things all the way through. We're very excited about how well you've all been doing. So we'll keep working with you to get you through that exam. And those of you who want to go on and do some sterile and non-sterile compounding, we'll be organizing that for January as well. So great job. Thank you.
So much, Kermit. All right. Ooh, we got okay. What are we saying? These 3. Also, B is 3. 1 second. 5B. Okay, so good question. So where was I? Oh yeah. So B is 3. So B benzonatate are otherwise known as Tessalon pearls. You guys heard of those before? Seen them? They look like kind of looks like if you've ever seen vitamin D2, it looks very similar to that. They're like little gel, like yellow, like spheres, like little tiny pearls. That's basically what they look like. And do you know what they're used for? Benzonatate? Cough suppression. Yeah. Do they work? Not that well, but it's again, placebo effects is useful. And it's one of the few, I guess, cough suppressants that is actually in like a tablet form, as opposed to say like a cough syrup or something. So a lot of times you see benzonatate. A lot. I feel like I would always see benzonatate with like COPD patients or patients with emphysema, and they would take that in addition to their inhalers, and they would say that it worked. If it worked for them, everyone's different. But yes, benzonatate, Tessalon pearls. The good thing is, I mean, because it's barely therapeutically active anyway, it really doesn't interact with any other drugs too. So you're going to be fine. It's not like it makes you drowsy or anything like that. All right. So what else do we have? A is 8. Liraglutide is otherwise known as Victoza. So what do we know? What do we think liraglutide and Victoza are for? Diabetes, yes. Liraglutide, it's a GLP-1 agonist, I believe. Yeah, so it's basically it helps. You would take it along with carefully along with a insulin or to replace insulin therapy, depending on what type of diabetes you have. It's mainly for it is for type 2 diabetes. It doesn't work on folks with type 1. Victoza is very similar to another medication. Oh, it's an injectable, by the way, too. So, and how do you know it's diabetes? Liraglu. It has that glucose in it, right? Liraglutide. Just like glipizide and glyburide and all those. Generally, those diabetes drugs have that GL something, that GL syllable sandwiched in there at some point. Now, you probably know about Victoza's more popular cousin, which is all the rage right now, because a side effect of Victoza, which is very nice for people with type 2 diabetes, is they can lose weight. Yeah. And they can usually they lose up to like 10%, 13% of their body weight. So whatever they started off with, they shave off 10% of it. And which is why Ozempic is in that same category. Yep. The jingle for it. But what's the side effect of Ozempic or Victoza? Because where do all those calories go that you're not actually metabolizing? If we remember, yeah, you excrete them, and you excrete them quite a bit if you're having Ozempic and Victoza, right? Because you're just not processing it. You're not processing those fat or carbs, so it's got to come out somewhere. That's what happens with that whole class of meds. But it's also, I mean, a lot of the weight loss drugs, though, that's Victoza and Ozempic are bad in that way, but a lot of the weight loss drugs are even worse. There's one, Orlistat. Orlistat it's an oral weight loss drug, and it's only for weight loss. I can't recall the brand name, but it's huge. I know it's generic, so it's generally just Orlistat. The good thing about Orlistat is that it's actually, you can give it to kids who are like 12 and up, and it's one of the few like pediatric like weight loss medications for these kids who are like severely obese. Like they might even have like genetic disorders or something like that, making them that obese. But the problem is, again, what Orlistat does, which is different from liraglutide and Victoza, but in case it comes up, Orlistat makes your body unable to process the fat within the foods that you ingest. So basically what happens is like if a kid eats a cheeseburger, they're going to get the proteins and carbohydrates from the cheeseburger, but none of the fat is going to be transferred. It's just going to get sort of soaked up by the Orlistat and then excreted. So what happens? They have this thing called steatorrhea. You know, diarrhea. Steatorrhea is just it's fats being excreted. So very not fun for. Can you imagine like a little kid in middle school, like who's taken Orlistat? Like I would not give that to any child in any school setting. Yeah, literally homeschool them that they're going to be on Orlistat. And it happens in something like 40% of the patients. So it's like a very common side effect. But it works. That's why Orlistat has been around for quite some time because it works so well. You just have to be able to deal with those side effects. And Ozempic and liraglutide, they work in a similar way. Not causing fat to be excreted, but just sort of helping with the insulin production and metabolism. But also, again, enhancing that excretion property. But enough of that crappy talk. Okay, we will go on to something else. We didn't do G. G is 7. Yeah, acyclovir or Zovirax. All right. How did we know that G was 7? Vir. Antiviral. Perfect. Yeah, herpes. So like it could be sexually transmitted and infections, STIs, or something as simple as a cold sore. So you can get like acyclovir creams and stuff like that put on cold sores, and it's very, very effective in treating them. Oftentimes over the counters, you know what also works really, really well for cold sores? And what is it? So for cold sores, what works really well actually is zinc, if you can believe it or not, because zinc, like just the element zinc, has antiviral properties. So there are like some creams with zinc or like little like chapsticks you can buy over the counter, and it's actually been shown to work quite well if you feel a cold sore coming on, or if you want to shorten the duration of time that you have a cold sore. It can be quite useful. Looks like I'm having some more people join us. Oh, yep, Nissa and Carolyn, hello. Perfect.
Hi. Hi, sorry I'm late.
There. Oh no, you're not late. You're coming at the normal time. And we're just getting into it, so you're all good. Let's see. So we just talked about, all right, so yes, antiviral, acyclovir, solid antiviral. What might be some things to expect with side effects associated with acyclovir or other antiviral medications? Similar to antibiotics. Could have nausea, vomiting, diarrhea, a little bit less so than antibiotics, but it still could. Yeah, I would say nausea and vomiting are the big ones. They're a bit more common with antivirals than antibiotics. Not to say that antibiotics are nausea and vomiting free, because they absolutely aren't, unfortunately. Plus, I mean, if the antibiotic causes nausea and vomiting and you're already feeling sick, like it's not too much to push you over the edge. Likewise with those antivirals. But aside from that, antivirals tend to end in that suffix that you notice, the VIR. So most drugs that end in VIR, I'd say 90% of the time, they are antiviral drugs. So if you don't recognize the drug, but it ends in VIR, just assume that it's an antiviral. They might be used to treat different viruses. For instance, like tenofovir, ritonavir, those are ones that are used to treat like HIV. It's another antiretroviral drug, but it's an antiviral nonetheless. So of course, you might not, there's no way to tell exactly which type of drug or which type of disease the antiviral treats, but you can always tell if it is an antiviral. All right, and then lastly, I think we just have to do escitalopram, right? So escitalopram is what? Lexapro. It is a happy pill. It's an SSRI. So it's rebalancing that serotonin within your brain. So, yeah. So escitalopram or Lexapro, it is literally the cousin of citalopram, the more expensive cousin. Yeah, yeah. So you know why it's called Lexapro, why it starts with L? Because it is they tagged a new little molecule on the side of citalopram onto the left side of citalopram. So it's left Lexapro. It's honestly, it's like a cash grab for the pharmaceutical company, because once their patent ends, they have any pharmaceutical company that comes up with the drug, they have exclusive rights to that drug, unless they waive those rights, which 9 times out of 10 they don't. They have exclusive rights for about 17 years from the start of when they're developing the drug to when it's officially hit the market. So what did the company that invented citalopram do? They tweaked it just a tiny little bit, and then bam, they have 17 more years of exclusivity with a drug that basically does the same thing, and they can charge more for it because it's, yeah. So, but it works just about as well. as citalopram does. And thank you for joining, Daliris. Great to have you. So yeah, so it works in a very, very similar way to citalopram. So what are some counseling points for our SSRIs in general, whether it's citalopram or escitalopram or Zoloft or you name it? Yeah, side effects, sure.
Well, they treat like mood disorders, right?
Yeah, so they'll treat like depression, or anxiety.
So it causes drowsiness.
Mm-hmm. Yeah, absolutely. Drowsiness, dizziness.
It makes you hungry.
They can cause weight gain, absolutely. Yeah.
Yeah, I'm with you.
Yeah, I'm just repeating for the but yeah, absolutely they could cause weight gain. Yeah, and certain ones cause more weight gain than others. Absolutely. And then certain ones work for people and don't. That's one of the mysteries of our brain medications in general. So lots of times if one SSRI doesn't work, they'll tweak it, they'll bring the dosage up, they'll bring the dosage down, or they'll switch you over to something else. So very oftentimes, and we don't entirely know why, the SSRIs will they'll switch until they get it right. Or they'll switch to something else like an SNRI or another mood medication. So yes, SSRIs like escitalopram and Lexapro, they work very well for depression. They work very well for anxiety disorders. So we're talking even generalized anxiety, PTSD, OCD, obsessive compulsive disorder. They can all be treated with SSRIs. One thing important to remember about SSRIs is the way you start them. You start SSRIs low and you gradually titrate up. So someone might start off with 10 milligrams, taking it once a day for a week, and then they'll go up to 20 milligrams the next week, and then maybe 40 milligrams the next week, and or until they reach a therapeutic effect. Because you want to go with the minimum effective dose because that minimizes the side effects. So also, another thing to make note of with SSRIs is, and this is it's one of the sad side effects, but it's very important that the patient knows this, is especially if they have depression, there is a risk of increased suicidal ideation. So not necessarily an increased risk that they'll commit suicide, but certainly an increased risk that they'll be thinking about it. And that's basically because as the SSRI tapers up, and you can taper up, like for instance, even after you've tapered, for OCD, SSRIs don't work to really treat the obsessive compulsive symptoms until about 8 to 10 weeks after you've been taking it at its full strength. For instance, with OCD. For depression, it's a bit sooner. It's more like 4 to 6 weeks, but that's still like a month. So if someone's depressed and they're given this SSRI medication and they're like, oh yeah, well you're gonna feel better, they're not gonna feel better right away, and they shouldn't think that they're gonna feel better right away. So they're gonna think that the medication might not necessarily be working. And the other thing with the suicidal ideation part of it is your mood is not necessarily related to your motivation, if that makes sense. So when people are depressed, they sort of lose motivation to do things, right? And they might be feeling really depressed, but they also have that lack of motivation or lack of enthusiasm about life, like they're tired. You tend to get the motivation back with SSRIs before you start feeling better. So that's how I kind of explain it. It's like, so that's why they get the suicidal ideation, because now they're finally motivated, but they're still very, very depressed. So that's why it's important to tell them that. So if they do start having thoughts like that, they can be like, oh, my pharmacist told me about this. I just have to keep taking the medication, just stick through it. In 2 or so weeks, it's all going to be better. But it's important that they know that's a side effect to prevent any problems like that. So, and I'll just review because we had a few people join us. So I'll just review which ones go where. So A is liraglutide that goes to Victoza, which is number 8. B is benzonatate, which goes to 3, Tessalon pearls. C is lamotrigine, that aligns with Lamictal, or 1. Losartan is Cozar, so D goes with 6. Lantus is insulin glargine, That's our long-acting insulin. So E goes with number 2. F is guaifenesin. Guaifenesin goes with Robitussin. It's our cough syrup. F is number 4. G is acyclovir. G goes with Zovirax, or number 7. And H is escitalopram, goes with Lexapro, which is number 5. All right, so as I switch, let's keep talking. Let's do some drug to drug class matching. So let's talk about these drugs, and we will match them to the correct drug class. So I'll give you guys a minute. This is a new one. And Polly, we also got Kaisha joining us. Yep. All right. Do you guys have some answers for me? Not yet. C1? What do we think, guys? Yes?
Yes.
Yes, it is. C is 1. So Zolotensin is an ACE inhibitor. Do you know the generic for that? Benazepril. Yeah, benazepril, benazepril. Perfect. And you know it's that ACE inhibitor because it's that pril drug, right? PRIL. And what was the side effect that I mentioned with our pril drugs? That's weird about it. Dry cough. Dry cough. Although I should note this with any sort of antihypertensive medication, whether it's an ACE inhibitor or an ARB or a water pill or you name it, you can get this thing called orthostatic hypotension. Anyone have an idea what that means? Orthostatic hypotension. So, okay, one at a time, please. Yeah, low blood pressure, dizziness upon standing, right? Low blood pressure because your blood pressure drops if you stand up too quickly from a seated position. So think like orthostatic, so like you're static, you're sitting, and then you rise up too quickly. What happens? You get a head rush, right? Because the blood, your blood pressure has already been lowered, and then by suddenly standing up, you can get very dizzy. So especially in older individuals or individuals who are taking other medication which might make them dizzy, we want to make sure that they're not standing up without maybe the assistance of a walker or a cane or some other device, or that if they do stand up, that they sort of do it slowly, and afterwards that maybe they wait a second or two to make sure they're okay before they go about their business. So yeah, orthostatic hypotension, quite common with our antihypertensive drugs. It's basically meaning they work too well, which isn't a bad thing, but it is a bad thing if the patient is a fall risk, right? Because that's the last thing we need is little grandma to stand up and then fall over and break a hip or something. B is 8, Novolog, one of our anti-diabetic medications. What kind of anti-diabetic medication is Novolog? Is it a pill? Is it? It's an injectable, right? What kind of injectable?
Insulin?
It's insulin. Yes, perfect. Score 1 for the those joining us online. Yeah. You got some You got some claps in the class. So yes, it is an insulin. Do we know what type of insulin is, or what the generic version of it is? Novolog is, of course, the brand name. So we had our long-acting insulin. That's Lantus, yeah, one of them. So Humalog is our insulin Lispro, which is rapid acting, right? So you take it for meals. You would also take Novolog around meals. Or you would take it regularly throughout the day. So it's like, it's not as rapid as your mealtime insulin. I believe it's considered short-acting insulin or insulin aspart. And insulin aspart is, its maximum onset of action, I think, is like 1 to 3 hours after you inject. So you wouldn't inject it right like before a meal, but you might inject it like morning, noon, and night, like throughout the day. And that, of course, depends on how well your diabetes is controlled. Now, oh yeah, one important thing, and this goes for anyone who uses insulin, who knows someone with diabetes. What do you think happens if someone is they're like sitting at a restaurant or something like that, and they're about to eat their meal, so they inject their rapid acting insulin, but then the restaurant is super busy, so they don't get their food. They're gonna have a low, right? So what we always say with rapid acting insulin, especially, so our Humalog is, even though it takes about 15 minutes to work, you don't take it 15 minutes before you eat. You take it with your first bite of food, and that prevents you from getting a low. So that's one of the most important things with rapid acting insulin, is you don't want to have that insulin trigger a low. So you want to have the food like on your plate, ready to go before you actually inject it. And that's something that poor people, like folks who are maybe they're just diagnosed with diabetes, or they're just using insulin for the first time, sometimes that's not something they think about, because who would think about it? It's kind of it's an easy oversight to make if you're not thinking about how the drug actively works within the body, right? So that's just my little counseling point for Novolog. All right. H is 6. Yes, quetiapine is an antipsychotic medication. So what kind of things would quetiapine be used for? Or actually, what's the generic for or what's the brand for Seroquel? Yes, Seroquel or quetiapine is the generic. So it's an antipsychotic. So what is it used for? Mood disorders. Mm-hmm. Potentially for bipolar, potentially for insomnia. They use it quite a lot, especially in like nursing homes as well, for like Alzheimer's or dementia patients, because they go through what's called sundowning. Yeah, yeah, exactly.
Are you
That,
on 8?
what is that? We're on we just moved from quetiapine so H is antipsychotic. So H goes to 6.
Would
8,
it be asking too much if we could go in order? Because I'm
I,
getting
so do we want to go in order, class? They're
like
yelling
we're
them out as
kind of
they know
all
them.
over the place. Huh?
Yeah. So we were doing the ones that we
Okay,
know
just do
first.
whatever works for you. It's
Okay.
fine.
I'm going between the two classes, but I will do the
Yeah.
review again of as we go through like A through H at the end.
Okay.
To make sure. But as of now, we're doing quetiapine for antipsychotics. So H. So what else? So yes, as I was saying, so sundowning, that's when the Alzheimer's or dementia patients, they get very confused, especially when the sun goes down. It's like later in the day, they're tired and they can get overly disoriented or sometimes aggressive. Yeah, sometimes, yeah. Yeah. So it's tough. So a lot of times they will dose them with quetiapine to as a form of sedation to keep them calmer. If it sometimes works, sometimes doesn't. Yeah. So it's also used for among other things, antipsychotics are used for acute sedation in people who are like aggressive in the ED or in the ER. Yeah, unfortunately, it doesn't always work. All right, so what is next? So we're doing A now. Okay, so mometasone is 5. Yes. So what is yeah, mometasone? Yeah, absolutely. It is a nasal spray. It's sometimes called Asmonex. So it is a corticosteroid. And so what type of medication then is it similar to? It's similar to prednisone. Yeah, it's in the same family of drugs as prednisone or dexamethasone or methylprednisolone or prednisolone. There's a whole bunch of corticosteroids. And what again were some side effects? Because not everyone was here the last time we were talking about prednisone. What again are some side effects of prednisone that we can expect? Mood swings potentially. Yeah, or changes in temperament, changes in mood. Sometimes people get a bit more aggressive with prednisone. You can also have people tend to eat more, right? So you can have weight gain. It makes you hungrier. Sometimes they have insomnia as well. Sort of gets your heart going, can get your heart pumping a little bit. Luckily with nasal sprays or with other like topical corticosteroids. So if you're using a topical corticosteroid or a nasal spray, generally it's not like a systemic corticosteroid that, and by systemic, I mean like you're taking a pill or you're getting it via an IV. That's where it's going through your whole body. In this case, the corticosteroid is just being localized. So it's acting just on the nose. Or if it were like a cream, a corticosteroid cream, for instance, it would just be acting on the skin. So maybe to treat hives or a rash or whatever you had going on. So yes, mometasone is a corticosteroid. Generally doesn't have as many of those systemic side effects, but it is still, especially if it's going to be administered by like orally, or in that case, there is always the chance of having the side effects. Okay, what's next? Which one's 7? G is 7, yes. So G is 7, so moxifloxacin, very fun to say, is a fluoroquinolone. What are our fluoroquinolones? They're antibiotics. Yeah, so what do they treat? Yeah, what type of infections? Could be skin, bacterial infections. Yeah, yeah. So as long as it's a bacterial skin infection, yeah, totally. They're also quite useful in patients who are allergic to amoxicillin or other things for respiratory, like bronchial infections. So like a bacterial like bronchitis or pneumonia, that kind of thing. So it's not first line for that. It's not the first choice. But if they're allergic to, say, penicillins or others, then we would probably go with amoxifloxacin. You also see moxifloxacin a lot as like eye drops as well, or ear drops. So they're quite useful for those upper respiratory infections or like eye infections, for instance. Let me see. Any side effects to be aware of with fluoroquinolones? There's one kind of weird one. Our fluoroquinolone antibiotics. Not as common with moxifloxacin, but ciprofloxacin. This side effect happens to maybe 1 in 50,000 people. Yeah. Well, you might. So, well, yeah, that happens in a lot more, but 1 in 50,000. Yeah, good thought, good thought. It's something you would not consider, but it is no, it's tendon rupture. So fluoroquinolones can, in very rare cases, They can cause Achilles tendon rupture. About 1 in 50,000. Yeah. And it has something to do with, yeah, I know how. I think if it's with certain people, if they're predisposed to it, it usually happens in older people. I think somehow the drug builds up in the body because fluoroquinolones do build up in the body fairly well, in fairly high concentrations, which is why they're good drugs. But I think they do cause like some breakdown of tendon tissue when they do that. And if your tendon's already weak or something, it can push it over the edge. Fun fact, Melissa has actually counseled on, been like a expert witness on like 2 cases of tendon rupture that are related to fluoroquinolone use. And each time, each time that happened, right? So the person's suing the pharmacist for not telling them that their tendon's going to rupture. Right.
No.
Yeah. Right, right. Because it's such a rare side effect. They don't generally counsel you on it. But most of the time, right? What happens if you're at the checkout at a Walgreens and you're picking up your moxifloxacin prescription? They're not going to tell you the rarest side effect there is, right? And or they're not even going to counsel you, or you're going to sign off saying like, "Oh, do you have any questions for the pharmacist today?" No? Okay. And that's what the legal defense was. That's the backup. Yeah. Well, that's what the legal defense was. So in neither case, the doctor or the pharmacist, neither of them were found liable because the patient waived their rights to be counseled. That is called. Absolutely. That is called. You document everything. You document or it didn't happen. Exactly. Exactly.
Wow.
So that's what to remember. So like Cipro, especially, you see Cipro all the time in the hospital, right? Ciprofloxacin. That's a tendon rupture potential. Yeah, yeah, you'll need surgery. You won't be able to walk. Yeah, it is nasty. It is nasty. And again, it's only like 1 in 50,000. But it's Achilles tendon. Yeah. Yeah. Oh yeah. I mean, you're off your feet for months. Yeah, totally. Close Mary, but nope. D is something else. I can see why you went with class is saying D is 2. Class is correct. Yes. So rabeprazole. That is exactly what it's for. So rabeprazole is used to treat GERD, which means it is a PPI, right? It's one of our prazole proton pump inhibitors. So just like omeprazole or lansoprazole, rabeprazole. So this is not a common one. Did anyone know the brand name? I don't even think it was in your top drugs, but they might have mentioned it. The brand name for rabeprazole? What is it? It's Acifex, yeah. Yeah, so it's like acid, right? Acid Fex. Yeah. So like it kind of gives you the hint as the brand name as to what it does, right? It reduces that stomach acid. Yeah, absolutely. And Brian, yes, on the next one, absolutely correct. So anything with rabeprazole, yeah, it's the same as counseling for omeprazole or pantoprazole or any of the other PPIs. Generally, you take it about 30 minutes before eating for it to be effective. They have long-lasting formulations, so they have XL or extended release formulations. So you get that like omeprazole 40 milligrams is extended release, so it goes for the whole day. So what's important to remember if we're thinking about medication safety? What's important to remember about extended release medications? No crushing, extended release, absolutely. Because they're meant to be released over time, and if you crush them, they're released all at once. So that's very important. So if it is for instance, I don't think rabeprazole comes in like an XL form or anything, but I know, hey there. I know that omeprazole does. They have like an extended release version of it. So you absolutely wouldn't crush that unless you open up the capsule and you're making it into a suspension or something if you're compounding it. That's the one time you would open up those extended release capsules, right?
What is the branding for
Ribeprazole, you know, it's Acifex. So like ACIPHEX. Yeah. Yeah.
200 drugs, right?
There you go. Yeah, the 200 drug list. Excellent. All right, so Brian online has given us the answer to E. Do we agree with Brian that the answer for E Cymbalta is what? Is 3 and SNRI. Perfect. So what's an SNRI? What is an SNRI? Cymbalta. It does have to do with neurotransmitters. That would be, yes, and Brian, a serotonin reuptake inhibitor. It is a serotonin reuptake inhibitor, but that N adds one more thing, and your spelling's good. Norepinephrine, yes, absolutely. So it regulates serotonin and norepinephrine. Book page 626, it jumps 80 to 85. So are we missing 5 or is it just me? That's probably a misprint, Mary. Is it 80 to 85? Oh wow, so it's literally just a misprint. So it's apparently it's every book. So you're not alone, Mary. Don't worry about it. Yeah, that's weird. So the book just skips it. Yeah. All right, let's see. So SNRIs, very, very similar to SSRIs, although they sometimes work. So if a person has cycled through a bunch of different SSRIs, remember how I was saying like trial and error. Yeah, Acacia, serotonin and norepinephrine. Perfect. Yeah, so the Cymbalta, it is a SNRI. Number 3. So as an SNRI, it's used for anxiety disorders again, or mood disorders. And it's also for, like, you could use it to treat OCD, you could use it to treat anxiety disorders. It's quite useful for those. Many times, if a person fails multiple SSRIs, meaning the SSRIs just don't work for the person, they might try an SNRI because it gives that, like, it's blocking the reuptake of not just serotonin, but also the norepinephrine, which should help further regulate the mood, which is really, really good. It works for quite a lot of people. So what is the generic for Cymbalta? That's the brand name. Duloxetine. Absolutely. The generic is duloxetine. And Cymbalta is one of those really cool SNRI medications that can also help with another condition. So not only does it help with anxiety and depression, but it can also help with something that's more of a physical ailment rather than just a mental issue. What could that be? You know, wait, I'm actually, you know, I'm so glad you said that actually, because that's because so they said erectile dysfunction in class, like being funny, but it's actually something I should talk about. So one of the big side effects that people complain about with SSRIs is erectile dysfunction. They get erectile dysfunction from SSRIs. So from our Lexapro or from our citalopram. Because it messes with the way your brain is thinking. And but SNRIs are known as being sort of the more like sex-friendly antidepressants because they're known for being a little bit less likely to cause erectile dysfunction. So if that is something that a man is complaining about after being prescribed an SSRI, they might switch him to an SNRI and then he'll be happier. So
Well,
Yeah, I mean, because you want to treat depression, right? So it's not helping if you give them another problem to worry about, right? It's so yes. So SSRIs actually they are very much known for causing erectile dysfunction. SNRIs might be a good alternative to that. And I know I don't have any questions on erectile dysfunction drugs, but we might as well talk about them because that is a possibility that they might be on your exam. So what are some examples of erectile dysfunction drugs? Viagra. Yeah. Oh yeah. What kind are they? What are phosphodiesterase? PDE5. PDE5, and they do all end in phil. Yeah. So sildenafil is your, yep. Sildenafil. Mm-hmm. Tadalafil, because you remember that by like a ta-da, yeah. Tadalafil, yeah. Right. So yeah, so those are but what is a contraindication, or what is something you have to be super careful about if someone is taking an erectile dysfunction medication? Who should be really careful about taking those? Anyone with
Heart attack?
heart attacks, yes, exactly. Anyone with a heart condition. Yeah, you have to be very careful, as well as people who again are like a fall risk. So I mean, if you got a grandpa who is, you know, getting up out of the bed a little too quickly, he could get that same orthostatic hypotension. That's absolutely dizziness upon standing. So yeah, but especially you would not give a PDE5 inhibitor with uh, any patient who was taking other like nitrates for chest pain. So if they're prescribed nitrates like Ismo or Imdur or like nitroglycerin is the generic. If they're prescribed anything like that, you would avoid giving them a a drug for their erectile dysfunction. You would recommend other things. Um, so yeah, so that's my fun tangent on ED. Let's see what else. Let's see. I think we had another. Yeah, Kaisha earlier said ceftriaxone is 4. Do we agree? Ceftriaxone is a cephalosporin. Correct? Correct. Very nice. So ceftriaxone, or F, is a cephalosporin. I mean, that's low-hanging fruit, isn't it? Cephalosporin, ceftriaxone. But what kind of medication is a cephalosporin? Anti-infective, yeah. Specifically an antibiotic, right? So cephalosporin is a class of antibiotics. They are related to penicillins. Although I think I mentioned in the last class as well, they're kind of like they're cousins to penicillins, or they're like descendants of penicillins. So even people with penicillin allergies can tend to still be able to take certain cephalosporins if they're structured differently enough from penicillin. I think it's something like 10% of people with a penicillin allergy absolutely can never take cephalosporins, but that means 9 out of 10 people can, which is really useful, especially in a hospital setting, because these cephalosporins they can be very broad spectrum antibiotics, meaning that they can cover a lot of diseases, including some drug-resistant diseases. So like MRSA or C. diff, for instance. Drug-resistant bacteria can get killed by these very broad spectrum cephalosporins. Now, ceftriaxone, anyone know the brand name for ceftriaxone? It does start with an R. Rocephin. Rocephin, yeah. But again, it still has that CEPH in it, the rocephin. So all of the cephalosporins, you can always tell a cephalosporin antibiotic because they all start with C and have some sort of like ceph in them. So there's like cefdinir, ceftriaxone, cefuroxime, if you look up cephalosporin antibiotics on Google, there's like a list of like 50 or 60 of them. There's a ton of them. But yeah, they have most of the same side effects that you would come to expect with any type of antibiotic, what are our the holy trinity of antibiotic side effects? What is it? Nausea, vomiting, diarrhea. Yes, right? All the antibiotics, when in doubt, nausea, vomiting, diarrhea. There's hardly a single one that doesn't have that as a side effect. Why do those antibiotics cause diarrhea? Sort of. That's part of the reason. It's absolutely has to do with the effect within the body, how it's fighting off the infection. But does the cephalosporin know, in this case, know what the good bacteria is and the bad bacteria? It just attacks everything. It's a flamethrower in the jungle. Like it's just burning down the whole thing. So, or carpet bombing, or however you want to think of it. So what happens? It gets rid of the good bacteria along with the bad bacteria, which is good because it cures your infection, but it leaves room for other things to colonize, like C. diff. C. diff is the reason why some of these broad spectrum antibiotics cause C. diff is because C. diff is drug resistant. And then and normally it's in our body to begin with, but it doesn't multiply as much because it gets outcompeted by all the other good bacteria. But when you get rid of everything else that's stopping C. diff from multiplying, what does it do? It's like, wow, I finally have space in here. So C. diff keeps going. So yeah, so ceftriaxone, cephalosporin. What's another important counseling point with antibiotics? No drinking. Yeah. Well, I mean, yes, so yeah, no drinking alcohol. I would say it's not like, I would say no drinking alcohol. It's not a complete contraindication with antibiotics. Yeah. Yes, we'll get to that. But I'll talk about the alcohol part first because certain antibiotics, absolutely, you can never drink on them. So a Flagyl, for instance, or metronidazole, that one you absolutely cannot drink while taking it. Because what will happen is it's called this disulfiram reaction that has to do with the antibiotic. That disulfiram reaction basically means the alcohol is instantly converted into this very nasty substance, which gives you immediately the worst hangover of your life, and you will also throw up profusely. The limit for metronidazole for that one? We had someone asking what's the limit for Flagyl, 0. Oh yeah, no, even just a little bit, you will get sick. Like if you drink communion wine, like in church, like you will get sick. Yeah. And it'll last for like 3 days after you're done taking it as well. However, with like ceftriaxone or like other penicillin antibiotics, you're not going to get sick from drinking alcohol with them. It's not good. It won't it's firstly, you shouldn't be drinking if you're feeling sick with a bacterial infection anyway. But if you did, it's not like it's going to make you throw up. It's just not good for you, and it might make the antibiotic work less well. Because it is going to interact with any sort of alcohol in your system, but it's not going to make you like deathly ill like a metronidazole would. Metronidazole also was prescribed in the past as a way of actually detoxing people from alcohol as well. It's that effective because, well, obviously, if you physically can't drink, you're not gonna be able to drink while you're taking it. What's that? What's stopping them from doing that? Because they don't want to be violently ill every time they take a sip of like alcohol. Well, again, like antibiotic resistance, and there's other drugs that have the same effect that aren't antibiotics. Ones that are specifically like acamprosate is one, which is specifically for like addiction or substance use disorder involving alcohol or other substances too. But it has a similar disulfiram reaction where if you ingest alcohol, you immediately throw it back up. Similar. It does work on cravings in a similar way to naltrexone, but it's a different reaction which causes that. So naltrexone works more on like the psychological rather than the physical withdrawal symptoms. Whereas a person prescribed acamprosate, they'll still have a craving to drink, but if they do drink, they're gonna have a very bad time. So it's kind of like conditioning in that way, which is not pretty and not fun for anyone involved. All right, so again, so we will just review for those joining us because I know people joined like midway through. Drug to drug class. So A, is mometasone. A goes to corticosteroids, so A is 5. B, Novolog, that is an example of an insulin. So B, Novolog, goes to anti-diabetic, which is 8. Low tensin, benazepril, that is going to, I got lost on the page, ACE inhibitor, so which is C. Rabeprazole or Acifex, that is D. D is paired with a PPI or proton pump inhibitor. Cymbalta is duloxetine. Duloxetine is a SNRI, that's number 3. Ceftriaxone is F, that's also known as Rocephin. F goes with cephalosporins. Moxifloxacin or Avelox, Vigamox are fluoroquinolone antibiotics. So G goes with 7, fluoroquinolone. And H is quetiapine, Seroquel. Seroquel goes with our antipsychotic medications, which is 6. Okay. So, one more matching. Drug to indication. So I will give you guys a few minutes. And as you notice, some of these are definitely drugs in the same classes we've been talking about. So use those word techniques, those suffixes and prefixes that you've been figuring out. And I've labeled this a lot like the test as well. They're going to always mix in brand and generic stuff and expect you to know which is which. All right, so what are we thinking? Drug to indication. C is 1. Yes, C is 1. Valacyclovir for viral infections. How do we know it's an antiviral? It ends in vir, right? Absolutely. So do we know what type of viruses valacyclovir is good for? Yep. What types of viruses would you prescribe valacyclovir for? Could be, yeah. Could be STDs. Yeah, definitely. If it was determined to be viral, at least, which isn't typical for STDs, but it could be. Also, I'd say 9 times out of 10, it's for cold sores, for herpes. Yeah. So yeah, valacyclovir. Do we know the brand name for it? Valtrex. Valtrex is it's the best brand name. It sounds like an alien. Like it's great, and it's really easy to remember too, because Valtrex, valacyclovir. Now, I got spam coming from New Haven, which is fun. I don't know anybody down there. And if it's Yale, New Haven, then they're just gonna have to deal with me not answering. I'm teaching. Brian in the chat has said F is 3. Do we agree? Prozac for depression. Absolutely, Brian. Prozac is for depression. What is the generic name for that? Yeah, absolutely. So in what type of medication is it? Antidepressant, but what type of antidepressants? It's an SSRI. It's an SSRI. So it's only blocking that serotonin. Yes, excellent. And Brian says so too. He agrees. Yep, selective serotonin reuptake inhibitor. So again, the way to remember how those work, because like, what does that mean? Selective serotonin reuptake inhibitor. So in the brain, you have your synapses, right? You've heard of like the synapse, right? The connections between the brain cells where the neurotransmitters go. What happens in folks who are depressed or have anxiety is the serotonin. I could draw this out. I'm not sure how well it would work for folks. So like bear with me on here. Well, actually, on the computer, let me show the diagram that I'll be explaining. I'll see if I can. Yeah, this is what I'm talking about. Okay. All right, so for folks in the online, this is what I'm going to be drawing on the board while I'm explaining it, okay? So, SSRIs. So let's look inside the brain. SSRIs, we have what this is like sort of how the synapse is shaped, right? And then there is a receptor, like our serotonin receptor, it's sort of shaped like this. So again, this is like microscopic, right? So the little serotonin is, I'll just draw like little circles. This is the serotonin, the neurotransmitter. It bunches up in here, inside the synapse. And the idea is for it to have any sort of effect, it has to hit the receptor, specifically hitting it on like the receptor sites. Oh yeah, absolutely, yeah. So to get onto the receptor, so to get to the receptor sites, it has to pass through this like synaptic space, the space right here, this like open space. And what happens in a healthy person or a mentally healthy person who doesn't have depression is the serotonin is quite easily transferred across this little space and hits the receptor, and it gets like the happy feeling that you get from serotonin, or at least the balanced feeling. Now, what happens in some cases in people with depression or anxiety disorders is any leftover, well, in a healthy person too, any leftover serotonin is just reabsorbed back into the synapse. It just goes back. Because there's a limited amount of receptor sites. If the serotonin is just hanging out in there, it'll undergo reuptake. It'll be reuptaked back into the original synapse, the presynaptic nerve ending. Now, what happens though in people with depression or people with anxiety disorders is before the serotonin even gets a chance to get to the receptor, it gets reuptake. All gets reuptake. So what's happening? Then they're not getting enough serotonin. It's not hitting the receptors. We get that, right? So the serotonin reuptake inhibitors, so like our Prozac, like our fluoxetine, like our citalopram or escitalopram, it goes through these little channels, right? To get out. The serotonin goes through these little channels to get out to the presynaptic space. Essentially what the inhibitors are doing, this is the drug, this is the fluoxetine or the Prozac or whatever. Once that serotonin goes out there, it tries to get back in, the drug blocks it. And it keeps it in the space for long enough for it to find its way to the receptors. And again, we get a happier person eventually. It's exactly like that, just with a different neurotransmitter. Yeah, it's very, very similar to how Narcan works, where it just blocks the effect of the receptors. Yeah, and that's pharmacology in general. Pharmacology is all about those receptors and blocking them strategically or not. Yeah, you're certified. You're certified. All right, very cool. So let's see. So we just did Prozac. What's next? H is 5. Lunesta for insomnia, right? That is a classic commercial. What's the commercial with Lunesta? It's the butterfly. It's a little Luna moth, right? The glowing butterfly that flies into the room and puts you to sleep at night, right? It's Lunesta. Do we know the generic name for Lunesta? It's hard to remember the generic name for it because no one ever uses it. It's one of our Z drugs, right? So the generic name is azopiclone. We remember our Z drugs have to do with sleep because, right? Like if you're falling asleep, it's like Z's, right? So what is the important thing before taking Lunesta or another Z drug? What's the more famous Z drug for sleep? What's the one where if you well, melatonin is a sleep aid, but it's not doesn't work in the same way because melatonin is just a hormone that you should naturally produce by yourself, which is well, yeah. So melatonin actually, that's a good point, Jason. So melatonin, it actually sort of wears off. You get a tolerance for it over time. So technically, melatonin, you're not supposed to take it for more than like 2 weeks straight, or else it just stops. It pretty much stops working for you. The thing is, melatonin, really the only thing that melatonin, like the FDA recommends it for, is actually jet lag.
I know the name of one of the psychotics that is useful to help you sleep, but
Uh-huh.
I can't get it out of my head.
Oh yeah. So another Z drug for sleep, you probably know it better as Ambien, right? So Ambien, otherwise known as Zolpidem, right? Another Z drug for sleep. Zolpidem is Ambien. Yeah. And how would you counsel someone who is using Ambien or Lunesta? What would you say?
Not, not drive,
Do not drive.
not get alcohol.
Don't drink alcohol with it.
Do not stop it without the focus psychiatrist or whatever.
I would say, yeah, definitely. Especially if you find that you're taking it and it's not working, or if you're having issues with it, don't suddenly discontinue it. Don't operate heavy machinery. Yeah, it could, and it is also it's a controlled substance. Do you know what schedule it is? What schedule would Ambien be? It's not a 2. It's a 4. Yeah. C4. C4. 4 are all like the sedating one. Like think of 4 as like it's all the like anxiety or like the sleep meds and a few others. But yeah, all of like the benzodiazepines, all the sleep meds, those are all C4. Yeah, they all fall under that category. Yeah, with very few exceptions. So yeah, so that's a big thing for Lunesta. Obviously, just take it when you're planning on going to sleep. Likewise with Ambien. All right. Did we cover? We have a few more to cover. Let's see. I think Brian said G is 2. Do we agree? G is 2. So what is G? Yeah, hypercholesterolemia. And what is the generic of G? Generic. It's atorvastatin. Very good. Yeah. So it's one of our statin medications for cholesterol. So lowering cholesterol in the body, all of our statins. And all of the generics for those statins, they all end the same way. Rosuvastatin, pravastatin, lovastatin, atorvastatin. And many of the brand names also end in OR for whatever reason. So it's like Lipitor, Crestor, Simvastatin, Zocor. A lot of them end in those OR endings. So they all in generic, they're all statin. The brand, many of them are OR, but I don't want you to think of that as a rule that anything ending in OR is always a statin because it's not. But many times if that's maybe a choice as one of the brand names, then I would go with the one ending in OR in general. So yeah, what should I know about statins? What would be some counseling points? Yeah. Careful with flushing with muscle pain. Yep. So some people, those are probably the two most common adverse effects associated with statin use, is that if the statin builds up in the body, it can aggregate within the muscles, and that causes rhabdomyolysis, or the breakdown, myolysis, the lysing or breaking down of myo or muscles, which is very, very painful. You can imagine if something is breaking down your muscles, that is not a pleasant experience. So that is a common, not so common, but I mean it's not an unheard of side effect or adverse effect related to statin use, especially as folks are just starting a statin. Now, if you experience muscle pain, it might just be that your dose of the statin is too high and that you would react better with a lower dose. So sometimes maybe if they're trying to see, well, let's get the cholesterol a little bit lower, so let's up your dose. The person suddenly starts having muscle pain, they might decrease the dose by 50% and they'll be fine. Or they might switch to a different statin medication, just another cousin of that. So they'll switch from Lipitor to Zocor. And for whatever reason, the person might tolerate Zocor better than Lipitor. And in that way, they might get treated better without the muscle pain, with just a different statin within that same class of anti-hypercholesterolemic medications. Okay. Those are the big things. They take them once a day. They're tablets. Aside from the potential for flushing or muscle pain, really very few side effects associated with them. You can take them with or without food. You can take them. There's only certain ones that generally you take them at night. It was the old wisdom that you're supposed to take your cholesterol medication at night because that's when your body makes some of the cholesterol. We now know that's not the case, although some old school doctors will probably still say take your statin in the evening rather than in the morning. But it doesn't make a whole ton of difference. Aside from that, yeah, that's just about it for statins. What do we have next? E is 7. Montelukast for asthma. Do we agree? Yes. Yes, Montelukast for asthma. What's cool about Montelukast? Is it an inhaler? It can be. Yeah, it can be. But so yeah, it can come in the well, what's the brand name? Singular. Yep. But it also comes in pills, which is the interesting thing about it, right? So it can be an inhaled medication, like a powder, but it's also very effective, and it's really the only oral asthma medication we have. Yeah, yeah. And it's yeah, and it's taken and it's taken to prevent asthma attacks. So it's taken as prophylaxis, right? So you take something for prophylaxis before you get sick, so you don't get sick. Yeah. Oh, yeah. And they do have the chewable ones for little kids. Yeah. Yeah. Absolutely. So Montelukast does come in chewable tablets. They're usually like beige with a little M on them. That's what they look like. And very well tolerated. It's safe in kids, obviously, so it has very few side effects. Sometimes even people just with very bad allergies take Montelukast like seasonally. Maybe they have asthma, but it's not that bad. But during allergy season, it is bad. The doctor might say, "Well, take the Montelukast daily during allergy season to prevent any attacks from flaring up." Oh, and yeah, she would take Flovent. Yeah, absolutely. Yeah, yeah, Flovent. Yeah, well, actually, let's talk about Flovent. What's the generic for Flovent? Also starts with F. It's a generic for Flovent because this is super common, either as a nasal spray or an inhaler. Oh, you were so close. You were so close. That's an antifungal, but it is fluticasone, which you were on the right track. Yeah, fluticasone, and that ends right with sone, right? So what kind of medication is it? Fluticasone. It's easier to see if it's written out. Cortisone. What kind of medication does that look like? It is a corticosteroid. It's a steroid. So it's a anti-inflammatory that's also a steroid. So that's why it works really, really well for allergy symptoms, because what are allergies doing to you? They're causing inflammation. Your body's reacting to the allergens by causing inflammation. So fluticasone or Flovent, super commonly prescribed during allergy season, or for people with chronic respiratory allergies. It can be either a nasal spray or an inhaler. Sometimes it's added as part of inhalers also for folks who have maybe COPD, emphysema, or other chronic respiratory conditions which require that kind of localized anti-inflammatory effect to help them breathe more easily, because it'll open up the airways that are otherwise inflamed. All right, excellent. I'm glad you mentioned Flonase. Or Flovent, same thing. It depends on if it's the inhaler or not. Let's see. As we go, Mary is telling me 4 is A. We agree Nebivolol is for hypertension. Yes, absolutely, Mary. So Nebivolol for hypertension. So what kind of medication is Nebivolol? Look at that ending. Ending's laughing at you. Mary's got it. It's a beta blocker. Right? All the beta blockers end in LOL. They're all laughing because their blood pressure is so well controlled. Okay? Nebivolol. Albuterol, even if we're gonna keep talking about inhalers like a ProAir. It's a beta blocker. Labetalol, Carvedilol, atenolol, or Tenormin. Those are all beta blockers, which cause the heart to beat more slowly and release some of the strain that the heart is otherwise going through if there is hypertension. So it decreases the blood pressure, and it also is quite useful in folks with heart failure too, because people with heart failure, their heart is enlarged and it takes a lot more energy for it to beat. So it kind of like eases up the muscles in the heart so it can beat a little bit easier, if that makes sense. So it helps folks with heart failure as well. So they might have hypertension or heart failure. You're going to prescribe them beta blockers. Now, anything to keep in mind when we're talking about our hypertension drugs like Nebivolol? Your grandma walks up to the pharmacy. What are you going to tell her about it? What's the most important thing? I mean, what would you want her to know? Are you just going to be like, okay, Graham, like, take this, come back in 90 days? Like, what do you want her to know about it? Well, if we're talking heart medications, what's it doing? It's lowering her blood pressure, right? No, it wouldn't help with that's an antiarrhythmic. Mary's saying no alcohol. You could have alcohol while taking a beta blocker, but I mean, if we're talking grandma, probably not a great idea if she's also, if she drank enough to maybe make her dizzy. And yeah, I mean, we can't say like, but yeah, I would say don't like overindulge if you were taking a beta blocker. I'd say be careful with standing again, right? Dizziness upon standing, because it's a blood pressure medication. It's lowering that blood pressure, so it's lowering that threshold for someone to maybe faint if they stand up too quickly. That orthostatic hypotension. So that's what you guys have got to be thinking about, right? As you're going through that. But aside from that, beta blockers are generally very well tolerated. And they can be used either systemically for those heart conditions or as like we were talking about, like albuterol with asthma. They can be used to decrease inflammation within the lungs. Working on different receptors, of course, but similar. All right. What else? I think we have 2 more, right? What's ketoconazole? Ketoconazole is 6. Fungal infection. Absolutely. Yeah, ketoconazole. They're part of our what we call the azole antifungals or azole antifungals. So lots of the antifungal medications, they end in azole. Now, don't mess them up with omeprazole, okay? Or rabeprazole. Those are prazoles. These are just azoles. So ketocon, but they are azole antifungals. They're their own class of antifungal medications, so they treat fungal infections, many different types of fungal infections as well. So ketoconazole is otherwise known as Nizoral. That's its brand name. But like actually Diane mentioned, fluconazole. That's an azole antifungal as well. Anyone know the brand name for fluconazole? It kind of sounds like, I always think it kind of sounds like a bird. And it does have FLU in it. Yeah, diflucan or diflucan, diflucan, right? I always think it sounds like toucan. But so diflucan is fluconazole. And fluconazole, what do you most often use fluconazole for? Ladies will know this. Well, a lot of times, yeah, yeast infections. Well, there you go. But any sort of UTI, they're like the go-to for any sort of UTIs. So for guys too. Um, but yes, so but it's very, very like that's the point of care therapy for like yeast infections and that kind of thing. Ketoconazole you see a lot more for say like athlete's foot or like for it's like ketoconazole gel that you'll put on like warts or things like that, other fungal infections in that same way. Yes.
I don't well, but I have a coworker
Mhm.
that had a fungal infection within the body.
Yeah.
And it told her.
Yeah, no, the fungus, especially when it gets systemic, fungus is really nasty. Like fungal meningitis, which does happen, right? A fungal infection of the brain, very, very difficult to treat because you can't treat it with antibiotics, you can't treat it with antivirals. Antifungals are very hard to get into the brain. So oftentimes what you're doing with that is you're just like pumping that person with steroids and treating the symptoms and just waiting for the infection to sort of run its course. That also happens quite unfortunately with patients with AIDS. They can get cryptococcal pneumonia, which is a fungal pneumonia, which is very, very difficult for a person who's not immunocompromised to get. But it's very, very difficult to treat, especially with their weakened immune systems. So they have to have these very, very powerful antifungal drugs that have horrible side effects on top of them already being weak, and it's just nasty. It's a very, very awful way to go. The interesting thing, this always sticks with me too from pharmacy school, and maybe this will help you just remember like antifungals in general. But for like cryptococcal pneumonia, there are two ways that my professors told me you could get cryptococcal pneumonia. The one is if you are an HIV patient, but cryptococcus can also be spread like if you live with pigeons. So because like pigeons carry cryptococcal like fungi, like that and it's just natural. And most people they don't get exposed to enough of it to cause any sort of problem. But like if you I don't know you're raising carrier pigeons or something and you're living with them, like that's the only other way you would get that pneumonia. Yeah, pigeons. But yeah, so ketoconazole is for fungal infection. It is an antifungal and azole antifungal. Okay, and then lastly, Focalin. Focalin is 8, right? Why? Because you need to focus with Focalin, right? For ADHD. What's ADHD? Attention deficit hyperactivity disorder. Also be used for ADD, which is just attention deficit disorder. If you have all the lack of attention, but you're not hyper, right? And what is the type of drug that Focalin is? What is the generic or what type of drug? I'm hearing the right first letter over there. Dexa something. What is it, Dexa? It's a long one, yeah. So you might be more familiar with Ritalin. Like, so what's Ritalin? What's the generic for Ritalin? That's the one for Focalin. Dexmethylphenidate is Focalin. Methylphenidate is Ritalin. So, yep, it's it's just like with the how I was saying like escitalopram and citalopram. Dexmethylphenidate is just the right isomer, so they stuck something onto the right of methylphenidate to increase that patent for a little bit longer. So it's almost the exact same drug. They're like twins. And yeah, so Focalin, it's a amphetamine, so it's a stimulant medication, which means it is Schedule what? What schedule is it? It's a controlled medication, right? You gotta show your ID to pick it up, right? In the pharmacy, if you're picking up ADHD meds. So then what schedule is it? Because you only got to show your ID for what? It's a Schedule 2, right? Schedule 2. Yeah, all 80. Yeah, well, almost all. Almost all. All the stimulant ones are. Yeah. Yeah, so it's a C2 or Schedule 2 drug. Yeah. Yeah, exactly. But yeah, methylphenidate, dexmethylphenidate, any mixed amphetamine salts, those are all going to be C2 drugs. How many refills do we get with C2s? 0, no refills. No refills whatsoever with C2s. Very good. All right. Yes, thank you, Mary. 0. So we'll just do real quick. We'll do the drug to indication again for those online who are trying to catch up. Nebivolol or Bistolic, that's A. A goes with hypertension. Ketoconazole or Nizoral, that's B. B goes with fungal infection. C is valacyclovir or Valtrex. C is a antiviral, otherwise known for a viral infection. Focalin, D, dexmethylphenidate. D goes with ADHD, which is 8. Montelukast or Singulair, that is E, that goes with asthma. Prozac or F, that's going to go with depression as an SSRI. Lipitor, atorvastatin is G. G is going to go as a hypercholesterolemia or high cholesterol. And then H, Lunesta, it's one of our Z drugs, the zocapone. H is going to go for 5 with insomnia. All right. Abbreviations. What does AD mean? No. What does AD mean? Is it ear or eye? AD. See, right there, AD. So what is it? Don't second guess yourselves. Well, I mean, you guys have basically said every one of them. Mary's got it right in the chat. So what does A mean? What does it stand for? No. So A stands for oral, right? AURAL, oral, right? So what does that mean? Has to do with what? Yep, right ear. And D? So O is I, U is both, and D, so if you speak, and S is left. S is left for sinister, right? That's the Latin for it, is sinister or sinistra, which is, because, left-handed people used to be of the devil or whatever it was, right? So, yeah. Yeah, but S is sinister, so it's S always stands for left, and D, if you speak Spanish, derecha, right? It's right. So it's Latin, it comes from that, or dexter. So it's sinister and dexter for left and right. Or if you prefer, izquierda, derecha. So, and then U is for both. So if it was AU, what is that telling me? Both ears. OU, both eyes, right? OS, Left eye, right? Ocular sinister, OD, right eye. Great. Yeah, so just always make sure to review that, to make sure you know your abbreviations. All right, the physician writes an order for a medication to be given AC. The pharmacy technician interprets this to mean you give the medication before meals, you give the medication after meals, you give the medication before noon, or you give the medication before bedtime. What are we thinking? Mary's got A. So what is it, A or B? Yeah, yeah. Before meals. Antes de comer, right? Yeah, yeah, exactly, right? Because again, it's that Latin. It's before eating, or before, I don't know the actual Latin term, but I remember antes de comer, which is in Spanish before you eat. So how would I say after meals? PC. Yes. Yeah. Yeah. And then so it would be PC. Perfect. Perfect, Mary. Give the medication before noon. So how would you write that? How would you write like every day before noon or before noon? Like how would you write that on a in a SIG, a prescription SIG? Well, to prevent errors, you would write it just like that, Jason. But um oh, other one, that would be before bedtime, Mary, but you're ahead of me. How would you say before bed? HS. Yep. Ora somni. Ora somni, right? Because somnifera or whatever it is in Latin, that's or somnolence, I think, is the term for like, what is it, like sleepwalking or something like that, or to go to sleep. But before noon, I would just write QAM every morning, right? QAM. Yeah, Q is each, and then AM in the morning. So every morning. Because that would automatically mean before noon, right? So yes, so AC, antes de comer, before meals. Let's do some law. Which of the following programs contain information on adverse events that have been reported to the FDA? So what are we thinking? C? What is C? What is C? Do you have Veris? I don't know the acronym off the top of my head. But Veris is correct. Yeah, Veris is correct. That is the online website. It's a website that you doctors, prescribers, or even patients can report vaccine-related adverse events. Or there it is. Yeah, Vaccine Adverse Events Reporting System, or VAERS. VAERS is a really good tool because it's quite easy to use and log an adverse event that might be attributable to a vaccine. The problem is many times adverse events, like if you've gotten a flu shot a week ago and then suddenly you have a heart attack and die in the hospital or something like that. Did the flu shot have anything to do with that? No. But is it going to be reported in VAERS potentially as something that happened in your medical report as they transfer that incident from the hospital and report it? Yes. So we get some very interesting data reported via VAERS that isn't always the most accurate, because like correlation is not causation, right? Just because you got a vaccine and you had some sort of unrelated medical event doesn't mean those two things are connected. But it's also very good for reporting, let's say, if a person faints after they get a vaccine. And since it's a reporting system that is throughout the whole country, people can report to VAERS, and then they can eventually come up with a side effect profile that's accurate. So they could say, well, according to our VAERS data, during these 5 years, about 1.5% of people who got the Tdap shot ended up fainting. So we can confidently say with thousands and thousands of pieces of data that that is about the prevalence of that side effect, post-marketing surveillance. Theirs is just made up. What is the DEA? Drug Enforcement Agency. And what does the DEA do? What's, I guess, for our purposes, what does the DEA do? They do drugs, yes. Let's be a little more specific. What are they? Well, that's the FDA. That's the Food and Drug Administration. But the DEA specifically is just drugs, right? The Drug Enforcement Agency. They do attempt to stop drug trafficking to varying results. Yeah, they attempt to regulate illegal sales. They are like the police they're the drug police, which also means they're in charge of doing what when it comes to classifying medication. They schedule the meds. So the DEA is in charge of all drug scheduling. So the DEA is the one that if a drug changes schedule or gets scheduled, the DEA is in charge of making that decision. Yes, I thank you for bringing that up because they're trying to reclassify marijuana from a C1 to a C3, and that literally just happened in the past like 2 weeks. A assistant secretary, Rachel Levine, assistant secretary for Health and Human Services, wrote a letter to the DEA recommending reclassification, which is a pretty big deal, considering that we have not had a classifying of marijuana or a reclassifying of it since it first became a C1 Controlled Substances Act, and that was in 1970. So it's been decades since we've had any sort of even government official recommend for the rescheduling. So obviously what she wrote is just a letter. It doesn't have any like power or anything, but it is a powerful recommendation from a sitting, appointed administration official to make the DEA's think about reclassifying marijuana to a Schedule 3, which I think makes a lot of sense actually, because C1 drugs are supposed to have no recognized medical use. And yet we have medical marijuana. We have it for used in pain with cancer patients, lotion CBD. I mean, yeah, it definitely has some therapeutic effects for little kids with seizure disorders, Epidiolex. Oh, Parkinson's, yeah. It can help out with Parkinson's symptoms too. Yeah, absolutely. Neurological symptoms. Yeah, very interesting. So it does make it, to me, it makes all the sense in the world to reclassify it. What's interesting is with that potential reclassification of marijuana or cannabis products, I'm sure the dispensaries in Massachusetts would not appreciate that, the recreational ones, because then suddenly they have to start locking up all of their products. And they probably need to apply for licenses very similar to pharmacies in order to operate and actually dispense it. Because then it becomes legal federally, and then the federal law is actually going to be enforced as opposed to just sort of ignoring them and letting them do their own thing. Yeah. So really cool stuff. Yeah. And then P&T, I was just thinking of pharmacy and therapeutics, like oftentimes hospitals will have a P&T committee. So if they're trying to see if they're going to get a new drug on their formulary, for example, or if they want to review a certain type of disease or a certain type of drug class, you'll have P&T committee. We'll meet every like month or so and we'll discuss it in a hospital. But that's not like a formal organization, and every hospital is run differently. So which auxiliary labels, our little labels, right? When we're printing them out in the pharmacy, this comes down to our pharmacy operations. Which auxiliary label would be best placed on a suspension? We had no hesitation saying A. Do we agree? Shakewell? So what's a suspension? Or like, what's the difference between like a suspension and a solution? What is the difference between a suspension and a solution? Yeah. So a suspension, it naturally separates over time. So it's like, especially like say if you have an omeprazole, maybe you compound an omeprazole solution, like a omeprazole suspension, I should say. And eventually, like you have to shake it up and make sure it's all mixed up. But some of those particles are going to settle at the bottom of the bottle. Suspension should always be shaken. It's A, yep. So shake well. Shake well before using. Although, with certain suspensions, you may have to refrigerate them. And I would actually always recommend refrigerating a suspension. Amoxicillin, yes, absolutely. Amoxicillin suspension is a perfect example. Not only should you refrigerate it to give it a better shelf life after it's been mixed up, you should also refrigerate it if you care about your kids having to taste it, because it is not the greatest flavor. That bubble gum does not taste like bubble gum. Yeah, no matter how much. But if it's colder, it goes down a little bit easier at least. So let's see. And then what would be a good drug for topical use only? Don't overthink this. A cream, right? Yeah. Yeah, exactly.
An ointment.
Yeah, an ointment, absolutely. Yep. Creams, ointments, any topical, right? For topical use only. Applied to skin, similarly with ointments or creams or stuff like that. Yeah, hydrocortisone, perfect. External use only, very similar. We went through refrigerated, very good. All right. Let's see. I'm not sure. You maybe went over this in your readings. If not, we're going to talk about it now. Which of the following is not a type of formulary? So do we know what a formulary is? Hear about a formulary in a hospital? So a formulary is essentially a list of drugs that the hospital pharmacy has. It's like its inventory list. Yes. So MedRec. Yeah. So MedRec is part of a form. All the drugs in the MedRec would be part of the formulary of the hospital. You can think of a formulary almost as like the menu of what the hospital keeps in stock. It's the menu for the pharmacy. So what do you think the difference is between then a closed and an open formulary? Yes. Yeah. Yeah. So that's absolutely right. Yeah, because so an open formulary, in a perfect world, everything would be an open formulary, but we do not live in a perfect world. You guys work at Bay State or Holyoke Medical Center. So the Bay State, for instance, and Holyoke Medical Center would both have closed formularies, meaning there are a set of drugs that like Medicare will decide to like reimburse for. They're usually the generic drugs. But outside of the formulary, like let's say this doctor orders like a brand medication where you only have the generic in, like, let's say for Rocephin, they want brand Rocephin as opposed to the ceftriaxone, which you are keeping in the pharmacy. Medicare or the insurance company, they're not going to pay for that brand medication when you have the generic already available to you. Therefore, the Rocephin is a non-formulary drug. So it's not reimbursed by the payer. Usually this is the brand name drugs, or like sort of the wonky drugs that aren't going to be kept, that aren't used very often or aren't on the formulary list. So a closed formulary is not reimbursed by the payer. Anything outside of it, of what's listed, is not reimbursed. An open formulary is sort of an ideal example. Closest thing to an open formulary might be like Mass General Hospital or something, or just a gigantic medical center. Actually, honestly, a lot of times VAs are similar to open formulary systems. They're still closed, but they have a ton of drugs available. An open formulary theoretically has no limits on whatever drug you want to use. So you want to use brand, you want to use generic, whatever it is, that's an open formulary. Okay. So the only other type of formulary is restricted. So in this case, the answer would be C. That's not a type of formulary. Because perpetual, that's usually just used with perpetual inventory. Exactly. Yeah. So have you guys heard of perpetual inventory? Yeah. Actually, no, Mila, do you want to explain perpetual inventory, like what that means? Like, I know it's kind of hard to explain too. Yeah, yeah. Yes, exactly. Yeah. So perpetual inventory, absolutely. So instead of, yeah, it's a perfect explanation, Mila. So instead of, yeah, but broadly, that's what it means. Yeah, yeah, exactly. So broadly, perpetual inventory is instead of like closing the whole pharmacy down and counting every single drug all at once, mhm, perpetual inventory is essentially you go through a little bit every day and you count up, say, like 10 medications. You'll have like what you guys will call in Bay State like cycle counts. Yeah. So cycle counts are where like the computer will spit out 10 different drugs to say like count all the metformin that we have in stock. And it'll say like 10 different drugs every single day and keeping the inventory perpetually. So you don't have to like shut down the whole pharmacy and do it all at once. Instead, it's sort of little by little. So you get a good idea of what's in the pharmacy at any given time. So that is what a perpetual inventory is, but it has nothing to do with formularies. The flip side of that, restricted. A restricted formulary is also kept by hospitals. These would be hospitals with closed formularies. So realistically, 95% of all hospitals. A restricted formulary is a list of drugs that are restricted for one reason or another. By that, I mean maybe they need prior authorizations in order to be used. So we've heard of PAs, right? Prior authorizations where the doctor has to write a note to the insurance company or whatever the payer is, justifying why the patient needs that medication. So it might be that this medication should only be used in special cases of antimicrobial resistance or for patients with very specific diagnoses. Then the doctor has to write that note, send it to the insurance company, and then they'll pay. But in that sense, the drug is restricted for use for anyone else in the formulary system. Likewise, drugs that have quantity limits. So like our C2 drugs that you can't have refills, for instance. You can only fill up to 30 days supply at a time. That would be an example of a drug with quantity limits. Or for step therapy. So again, kind of this goes along with prior authorizations as well. Oftentimes, a medication will be restricted. Let's say, again, I'll use antibiotics as the example. There's some antibiotics that are really, really powerful and can go and destroy even the most drug-resistant bacteria. But we use them very sparingly because we don't want to use the last thing in our arsenal and then have that bacteria become drug resistant to all the antibiotics we have, right? So if a patient has gone through 1, 2, 3 different antibiotics and it still hasn't worked, the next step in that step therapy, that sequence of therapeutic tries, is going to be restricted. So it's going to be one of those restricted super antibiotics from that restricted formulary. Make sense? Gotcha. All right, so we have our 3 types of formularies: are closed, open, and restricted. 9 times out of 10, actually 99 times out of 100, you're always going to have a closed formulary to varying degrees. This goes back to what Jason was saying. Which of the following defines a solvent? We're talking about suspensions and solutions and solvents. So what is a solvent? Water is a good example of a solvent. Okay, D. We got a C over here too. There we go. Say it louder for the people in the back. The solute in the solvent. Yeah. So a solution is the solute plus the solvent. That makes a solution. So the answer is D, the larger part of the solution. The solvent is always what you are dissolving the solute in. So for instance, in our amoxicillin, when we mix it up at the pharmacy, it's the powder. The powder is the solute. The antibiotic is the solute. If we add water, water is our solvent, which dissolves the powder to create a solution. Okay? So the solvent usually isn't the active ingredient. Whenever we're talking about the active ingredient, that is the drug. The active ingredient is always the drug because that's what we are, that's the active part of the medication. That's what's giving the therapeutic effect. It's actively doing that. All right. Epilepsy is caused by excessive blank activity within the brain. Correct, Brian. Very good. What are we thinking? So what is epilepsy? Causes seizures, seizure disorder, right? And seizures are what we call electrochemical reactions. So it's electrical activity within the brain. It can be, seizures can be triggered by that, yeah, by strobes. Yeah. Well, no, but it's electrical activity within the, because the brain is, the nerves within the brain and within the body, they're governed by electrical impulses, right? That's how they, one nerve, the nerve on my toe talks to my brain through electrical impulses. So a variance or a disruption of electrical activity within the brain, that's what causes seizures. Now, other things can potentially, chemical imbalances in the brain, that's what causes, depression, anxiety. That's what I was talking about with like our SSRIs. Likewise with hormones, that can cause problems within and brain function too. And blood flow, of course, this is like the 5th time I've mentioned it tonight. Dizziness upon standing, right? If you don't have enough blood flow to the brain, you faint. But electrical impulses are what causes seizures and how the brain talks with every other area of the body through the nervous system. All right, so going off of that, which of these drugs can treat epilepsy? Going A? You're an A? I got a B in the chat as well. What are we thinking? Okay, well, what can we eliminate right off the bat? Wellbutrin and Zoloft, right? Wellbutrin, you can never give to people with epilepsy because it can cause seizures. E is used to treat bipolar disorder. Yeah, so lithium is used to treat bipolar and mood disorders. So I guess that brings us down to A or B, right? Yeah, what do you use epinephrine for? Are we talking like Pulp Fiction? Is that what you're, yeah. Well, epinephrine, I mean, it's for, yeah, like an EpiPen, right? Yeah. So, I mean, it's gonna be phenytoin, right? Phenytoin or Dilantin. That's our seizure med. Especially you can get it IV form as well in the hospital. Quite common. Very old school medication too. It's been around forever. So it has lots of side effects. But it's a very effective anti-seizure medication. So people with epilepsy can be treated with phenytoin, especially if they're having like acute seizures. Like if they especially have a seizure, they might put them on some phenytoin, at least for a short period of time before they can get stabilized and just use their regular, whether it's like lamotrigine or whatever they normally take. Yeah. All right. After administering a drug, the time when the body first starts to respond to the medication is called what? So we're thinking of ADME, right? We're thinking of our pharmacokinetics, the movement of drugs through the body. What makes the most sense? After administering the drug, when the body first starts to respond to a medication, what's that called? B, onset of action, right? That's the onset of action. That's how quickly you can expect to feel the effect of a drug. What drug or what type of drugs has the quickest onset of action? IV drugs, totally. I would say IV drugs or like inhaled drugs. So I'm thinking like anesthetics. If they're putting you to sleep for a surgery, that's pretty dang quick. That'll knock you out, right?
You don't even get to 10.
You don't even get to 10. You don't even get to 10. So yeah, so oftentimes like it's inhaled medications are very, very quick. They quickly get into the bloodstream where they need to go. But IV drugs probably have the fastest, like just pharmaceutically the fastest. The onset of action for an IV drug, because essentially what you're doing if you're putting a drug directly into the vein is you're bypassing the absorption phase, that first phase of ADME entirely. You're just bypassing it. So the onset of action for an IV drug is usually within like 15 to 30 seconds. It's literally that quick. If you were to look at it on a graph, sometimes we have graphs that show like the onset of action for certain drugs. And usually, like if it's just like a random graph, if it's an oral drug, it's probably going to look something like this, right? If it's an IV drug, the curve itself, this is 0, and this is like, I don't know, 1 hour or something. So usually it takes 30 minutes to an hour for an oral drug to really kick in. If it's an IV drug, the curve literally looks like this. Perfect 100% absorption almost immediately. And then it just decreases from there as it works its way through the rest of the pharmacokinetic process, through the rest of absorption. It distributes to the body, metabolizes, and then gets excreted and eliminated. So a plateau effect, that's what we think of when we think of like our long-acting insulin, for instance. It has most drugs have peaks and things like that, but in insulin and certain other long-lasting drugs, they can kind of plateau and sort of stay at the same level until they get eliminated by the body. The peak plasma level, the peak level of the drug in the blood would be like right here or right here, depending on which drug you were administering. And then the half-life of a drug is just how long it takes for half or 50% of that initial dose to leave the body. So that's the half-life of the drug. And usually drugs are completely eliminated out of your system by about 5 to 6 half-lives. So, and the half-lives can vary wildly between the drugs. So the half-life of like anesthetics is quite short usually. The half-life of some other drugs like amiodarone, they can go on for days. So certain drugs accumulate very well in the body. Certain drugs are eliminated very, very quickly. All right, just a few more. Thank you guys for also, you guys are the real ones for the ones who showed up at 5 and are still hanging in there with me. Trust me, I wasn't expecting to lecture this long either, but it's fun talking with you guys. All right, a patient asks a pharmacy technician if it's okay to drink grapefruit juice every day while taking Coumadin. A pharmacy technician should do what? Tell the patient that grapefruit is contraindicated while taking Coumadin. Tell the patient drinking grapefruit juice is okay. Refer the patient to the pharmacist, or tell the patient to call his doctor. Saying, hey, are you a pharmacist? Yeah. You go to refer the patient to the pharmacist, but since you are passing this course, so it is C, but technically,
Well, is it considered like counseling?
that is considered counseling, exactly, which is why you can't do it. So that's why it's up to the pharmacist to
Do
do
you
it.
have any questions in the pharmacy?
Yes. Exactly. You refer the patient to the pharmacist. But but what do you think what would the pharmacist's answer be then? What do you think? So, tell him, don't bother me. I'm 50 scripts behind. Call your doctor. Yeah, honestly, you could probably tell them drinking the grapefruit is okay as long as they limit it to having that 1 glass every day. Because the whole thing with warfarin and Coumadin, it's like consistency is key. So it's the big thing that messes with warfarin is you can have leafy greens as long as you have one salad every day, because they can adjust the dose to account for that one salad that you're having. Likewise, for that one glass of grapefruit juice, if you keep it consistent, you won't have a problem. However, if you suddenly decide to become a vegetarian, or you're suddenly like, wow, I love grapefruit juice, I'm gonna go up it to a gallon, that's when you're gonna run into problems. So it's so dosing with warfarin is very, very dynamic. It has a ton of drug interactions, drug food interactions. I will say now, if you get a question about drug interactions and warfarin is one of the choices, I would say probably it's going to be the answer, just considering how many drug interactions warfarin had. So yeah, you will be a reasonable and prudent pharmacy technician and refer them to the reasonable and prudent pharmacist who should hopefully have the time to counsel them.
And I'll have like,
And you will.
that's what they thought.
So let's talk about something that you're not going to deal with in the hospital most likely, but might appear on the exam. Medicare Part What provides prescription coverage? D for drugs, right? Medicare Part D. Yeah, Medicare Part D provides prescription coverage. What do A, B, and C do? You know? Part A is just for hospital or inpatient. And then Part B is for Medicare outpatient. Yep. And then C. Yeah. And then C. The one. Yeah, it can. So it's an Advantage plan, Medicare Advantage. So it could be like doctor visits or like extra like dental, like oftentimes it's paired with private insurance as well. But Part D is easy to remember because D stands for drugs, right? Medicare Part D. How many refills are allowed on C3 drugs? What are we thinking? I have heard every single answer except except one.
So it was medication. It was Medicare D.
Yeah, Medicare Part D is for your prescription drug insurance.
Thank you.
Outpatient. Medicare B is for outpatient. Yep. So Medicare Part B is what you're using if you're picking up at the pharmacy. Yeah. So how many refills for C3 drugs? You can get refills on C3. What are some examples of Schedule 3 drugs? No, that's not scheduled. C3 drug might be Tylenol with codeine, Tylenol number 3. Could be testosterone, steroids. No, Vicodin's 2. Yeah. Ketamine, Schedule 3. S-ketamine specifically. You're
Diabetic drug on medications. Some of them you could like.
They're not C3 though. They're not C3s. Because these are, remember, the schedules mean like they have the potential for abuse or misuse. And you can't really, I mean, you can use your insulin incorrectly, but you're not gonna get high off it, right? It's a So, well, how many refills are allowed for C2s? 0, correct. So then how many refills would be allowed for C3s? I wish it were 1, but it's not. It's 5. Maximum of 5. Although in certain places, like you can have no more than a 30-day supply at a time for C3 drugs. So for mass law, you can only have a 30-day supply, but you can refill that same prescription up to 5 times. And it's up to 5 times or within 6 months of when the prescription was written. So the prescription expires after 6 months, regardless of how many times you have filled it. So for C3 drugs, the limit is 5 refills. Okay. For C2s, it is 0. All right. So the answer is A, 5. Which of the following is true when it comes to needle recapping? Use both hands to bend needles after they have been used. Recapping a needle is unnecessary and dangerous. Use both hands to recap a used needle, or always wear gloves when removing used needles from a syringe. B. It is unnecessary and dangerous. Yes, absolutely. So we don't like to recap. Although you do always want to wear gloves when you're giving immunizations. We're talking, the question specifically talking about recapping, right? Recapping the needle after you use it. Many times they have the nice needles, the nice syringes where they're the safety syringes. Yeah, they snap right back after you use them. So it encases the needle immediately. The needle just retracts, and then you don't have any risk for being stuck with it, which is really good. But if it's an old school medication, or it's an old school syringe, or just certain vaccines, they're like that, where they don't retract, you're just better off putting it straight into the sharps container. Absolutely. Okay, here's one that's actually, it's quite useful for you guys, because you can use this to check out meds in your own medicine cabinet when you get home. A drug label indicates that it will expire in October of 2022. What was the exact date that it will expire out of these options? Is it the 1st of October? Is it September 30th? Is it Halloween? Or is it November 1st? Mary, you are correct. What do you think? It's an interesting question, right? Because a lot of the drugs will, sometimes if you're lucky, they will have an actual expiration like day, but many times it's just the month and the year. So what do you guys think? How long after?
My mind is fired, like several months. So I would say
Evelyn thinks C, 1031? 1031? You're right, 1031. Yeah, so it's the end of whatever month is there. So last day of the month. It's good. It's true. Yeah, yeah. You have to know how many days are in the months.
October always goes to the 31st.
Yeah, Halloween. Yeah.
Yeah, I know.
Oh, nice. That's scary. Yeah, sure. Mhm.
Like a pharmacy card. And I'll- so we got the majority of the worst employees. It's fine.
Yeah.
But I think that's,
Mhm.
like, at what point the medication is considered expired?
That's a great question. So, like, at what point is a medication actually considered expired? Yeah, I mentioned it. Yeah, yeah. So it's like, yeah. So like, so if I take this drug on November 1st, I'm essentially going to get the same experience as I got the full medication. Expiration dates are sort of like best used by dates in a grocery store. It's like it's best used by or best sold by dates. Um, exactly. That expiration date represents the point in which the company cannot guarantee that you're going to get the full therapeutic effect of the drug. Now, will you get maybe, if you're taking it November 1st, are you going to get 95% of the therapeutic effect? Probably, depending on how that medication's been stored. And then there's certain medications like aspirin, for instance. Aspirin, after its expiration date, really does break down, and it gets sort of, especially if it gets exposed to moisture, it gets rendered pretty ineffective fairly quickly. But many medications you can use perfectly well after their expiration dates. It's just not recommended if you're not like on a mission trip and in need of anything, which is better than nothing. But yeah, excellent question. So yeah, I mean, it's like with painkillers, like, and I mean, that's the thing too, because you want to take any sort of medication that you're taking for a therapeutic effect. You want to make sure you're getting the full benefit of that medication. You don't want it to be like I mean, if you have a painkiller, you don't want that stuff running out before it's time to take your next painkiller, right? Because that defeats the whole purpose. But yeah, expiration dates legally, like this is when we would throw it out in pharmacy. but you know, realistically, in the real world, in Jamaica, you can use it for quite some time afterwards. Yeah, yeah, totally, totally, absolutely. In a pharmacy, yeah, because
Yeah.
it gets checked. Usually, they get thrown out like a month in advance. It's like before the patient would get that supply. Um, I mean, it's not perfect, but yeah, chances are you're not getting expired meds. um, this is a little bit of a misleading question, but this is emblematic of what might be asked on the exam if they have a very narrow definition of what certain medication classes are used for. So SSRIs might be used to treat the following conditions, except what? Why OCD? We talked about. I mentioned SSRIs for OCD. You totally use them. Yeah, it was briefly. Yeah. No. Well, I think. Well, okay. So think about it. What happens to a person in bipolar disorder? What if they have bipolar? What do they have? They have highs and lows, right? Okay. So, if they get prescribed an SSRI, that's gonna moderate their mood so they're happier, right? So if they're depressed, if they're in their low part of bipolar disorder, they're gonna be happier because they're on their SSRI. What happens when they suddenly switch and get manic, and then they're also taking the SSRI? What will that do? Yes. So which is why we generally don't like to prescribe SSRIs for people with bipolar disorder, simply because it only treats literally half of their disorder. And the other half, it just makes it worse. Yeah. Yeah. Or it could even worse, it could trigger a manic episode with the person if they're taking it. So sometimes people with like mood or personality disorders, they can take SSRIs. But we generally avoid in people with like especially bipolar 1 disorder, which is like the one that is the classic sort of manic depressive sequence of events. We avoid SSRIs if possible. Instead, we want to treat them with lithium. We want to treat them with valproate, divalproex. All right, very good. I got 2 more questions for you guys, so you can get through them. Yes, we have provided. Sharon has provided. All right. Which of the following drugs may be used to treat gastroesophageal reflux disease? Omeprazole, fluconazole, alendronate, Lasix, scopolamine. We talked about this, right? What are we looking for? We're looking for our prazols, right? Not our azole antifungals, right? They don't have athlete's foot, they got reflux. So what are we giving them? We give them Prilosec, omeprazole, right? Omeprazole. So A. So A, omeprazole for GERD, or gastroesophageal reflux disease. And lastly, our last one, which of the following is a C4? C4 drug. Schedule 4 drug. Well, think about these are all brand names, so think about what's in them, what the generics are. I'll tell you, the cheat code with Tylenol number 3 is tells you what schedule it is right in the name. I mean, yes, it has codeine in it, yeah. So Tylenol number 3 is a schedule 3, so it's not B. Very good, Shamika. What'd she say? Well, what's Vicodin? What's Vicodin? What's
C3, right?
Vicodin is very strong. It's hydrocodone and acetaminophen. It's a C2. It's a C2, right? That goes in the safe. And what did I say about all the benzodiazepine, all the sleep drugs, all the sleepy drugs? They are all going to be what schedule? Schedule 4.
Four.
Yeah. IV. So Xanax. Xanax is alprazolam, right? It's a benzodiazepine. Yeah. So Xanax is a Schedule 4 drug, a C4 drug. Well, it's for anxiety. Those anti-anxiety benzodiazepine drugs, those are all C4s. Lyrica, pregabalin, that's a C5. All right. So I gave you a little bit of everything in this last one. But that's all I've got for you tonight. Yes, I can put this on Canvas. I have a bunch of stuff to upload as well on Canvas, so I'll have the previous lectures as well as this. It's just gonna take a while to download 3 hours of lecture materials to my computer, but we'll get there. Okay, well, thank you so much, guys. Oh, Polly, do you want to? Okay, guys, one more thing before we go. You guys.
Right, I can do that. We do have the 2 lab sessions, and I've asked most of you the 2 additional lab sessions on the 5th and the 19th. So please let us know. We just don't want these guys to show up and have no one there. So that's if you've missed one or if you want extra practice, they'll do either. We can set up study sessions if anyone wants. We're going to be. And I'm also going to set up a couple dates and times just to recommend you go get your certification at that time. Sometimes deadlines help, and you might be able to get a group to study with you for that. So we'll get that out to you. And
Can she move closer? Because we kind of can't hear her.
Oh yeah. So cool. Polly, after they get a chance.
okay. So
What about the map? Practice.
you want some more math practice?
Yes.
Okay, we can set that up. We'll see if we can set that up and get a note to you.
Okay. Thank you.
So did you miss everything? So we've got first of all, we want to thank everyone. We've had a great time with this group. Enjoy the enthusiasm and the interest. The hospitals are just so ready for getting some of you on board. But we do have the 2 additional sessions on October 5th and 19th for labs. For anyone who wants some extra practice or had to make up, we have a couple people that had to make up some. We also, if you need any help with your certification, your not your certification, your tech, Pharm tech and training certificate, we need to get those through. So please get in touch with us for that. And looks like we'll be setting up a math camp. And if there's anything else, please get in touch. And it was great to work with you all. Everybody good?
Yeah, great. Thank you. I have a quick question though, because I do have a lended laptop. Can we bring those in tomorrow, or do they have to be
Absolutely. We have Christine, who sits in the front area in front. She can take those from you. Does that work?
Yeah, sorry, I was having mic issues. What time is she there till? Because I work until 5, so.
Oh, she usually leaves before that. Nissa, which hospital are you at?
I'm at Bay State. I'm at 140 High Street though. So
Okay, Bay State, yeah. Are you gonna be coming to any of the other labs?
So yeah, I signed up. I emailed whoever was in charge of the sign up that I needed to do the October 5th makeup lab.
Okay, so why don't you bring it then and we'll get it from you then?
All right, cool. Great. I just wanted to make sure because I know Melissa was very adamant that we had to get these turned in and stuff.
Yes, I appreciate your following up on that, and I'll be reaching out to the others, so, excellent. Anyone else have anything?
Great. Have a good night.
You too.
What's gonna be the next step now?
So the next step is, setting up the, your time for your exam when you're ready. So we'll have the practice exams out. I think you're done with your labs and I don't think we're gonna come in anymore. So it's just practicing and getting ready for your, certification exam.
Okay, perfect. Thank you.
Thank you. Anyone else? Thank you all. Have a good night.
I'm nervous.
What was that?
You
Shanika?
as well.
Oh, thank you.
I said I'm
Bye.
nervous, but we gonna get through it.
Yeah, you're doing great.
Thank you. Okay, so it's okay for us to leave? Hello? I'm gonna leave.